Welcome, everybody. My name's Michael Fine. I'm a writer and community organizer, a family doctor, and a public health guy, and president and board chair of Primary Care for All Americans. Thank you for joining us tonight as we move from admiring the problem to beginning to fix the reality on the ground. Thank you for joining people from 40 states and 322 zip codes who are building a movement in a healthcare system for the United States that is for people, not for profit, and starts by providing primary care to everyone in every American neighborhood and community. Man, are we starting to rock and roll. And we've got 4 operating groups, now 5, a process for training facilitators that we tried a week ago and is fantastic. Thanks, Jack, for that. Conversations with important community and professional organizations from around the country. Thanks to all the people who are stepping up and volunteering to help. We have a social media team of volunteers, a playbook writing team of volunteers, and volunteers, editors and copywriters, video producers and fundraisers, even a couple of volunteer trombone players, and 1 or 2 other interesting musicians who we hope to bring on the Zoom, one Zoom in the future. Please volunteer to help if you haven't already. We need everybody. We're excited to switch things up this week, but before I steal the show, it's my great pleasure to introduce our moderator for the evening, Dr. Aliyah Shafi, and to thank the Zoom Committee for Primary Care for All Americans, which organized the Zoom and all the presenters, and John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Dr. Shafi.
Thank you, Dr. Fine. Hi, everyone. I'm Aaliyah. I'm a family medicine resident, originally born and raised in Queens, New York. I'm currently working at Jamaica Hospital in beautiful Queens. I want to thank you all for coming tonight. Being here makes you a part of building this movement with us as we break the stranglehold to provide healthcare for people and not for profit in every neighborhood and community. Primary care for all Americans. Tonight, we're here to roll up our sleeves and get to work. Instead of a main speaker, we're going to do breakout sessions tonight. We'll give you a chance to talk to each other and members of our steering committee and members of the board, or gather with others in the work groups and focus at the task at hand. If this works, we'll change the Zoom schedule going forward. We'll meet every 2 weeks. We'll make sure 1 meeting a month is dedicated to action and the other is dedicated to a speaker. So before we start that, we'll shake things up. Before that, we've asked Zulema Gomez to help the Cardona family tell us about their experience with healthcare. Hi, Zulema.
Hi, can you guys hear me?
Yes, we can hear you.
Hi, everyone. My name is Zulema Gomez, and I am the Director of Constituent Services and Health for the City of Central Falls in Rhode Island. I'm sure Dr. Fine has talked about our 1 square mile city. But I am here with the Cardona family who has benefited from having access to primary care. Familia Cardona, ¿estás en línea?
Sí.
Okay. So I'm going to introduce the Cardona family, and I'm going to ask for her first name, where she's from, and where she lives now. Gloria, ¿nos podrías decir su primer nombre y de dónde eres y dónde vives ahora?
Mi nombre es Gloria Cardona Cortés. Yo soy de Guatemala. Estoy viviendo aquí en Central Falls, Rhode Island.
Hi, my name is Gloria Cardona, and I am from Guatemala, and I now live in Central Falls, Rhode Island. So Anthony is one of her 3 children, one of 3 children in her family, and was born in Guatemala. For years, he's had undiagnosed asthma. He was bouncing between providers with limited preventive care and to what was affordable and required. So I will be asking Ms. Cardona what has changed for her since she's had a regular doctor now. Señora Cardona, ¿qué ha cambiado ahora desde que ustedes han tenido un doctor regular para sus hijos?
Bueno, ha cambiado muchas cosas buenas, porque desde que mi hijo tiene a la doctora Nelkin, bueno, en Guatemala, nunca me dijeron que él tenía asma hasta que llegamos aquí y la doctora empezó a hacerle estudios. Ya ella me dijo que él tenía asma, pero gracias a Dios y a los medicamentos que ella le ha dado, su asma de él ha desaparecido.
She said that when she was in Guatemala, they didn't know what he had. So when he came here to the United States, she was lucky enough to find Dr. Nelkin, who's a pediatric doctor in Central Falls, who diagnosed him with asthma. And since then, having access to Dr. Nelkin and having a regular doctor, Anthony has been able to get medications and has been able to benefit from seeing a bilingual nutritionist as well.
Wow. Thank you so much, Miss Gloria and Zalima. Hearing about what can happen for kids like Anthony when they have a PCP, a good one at that, is very motivating. This is exactly what we want for every child and adult in America. Now, are you all ready to get to work? Patty, please walk us through the next steps.
Well, hey everyone. I am super excited to be joining you guys today. Thank you, Dr. Shafi. As had been said, again, I will repeat, this is an exciting next step for PC4AA because you are stepping up and rolling up your sleeves to work together. So we are going to break out into groups that'll have about 30 minutes to talk and work together, discuss specific roles or topics. And then afterwards, we'll come back together to hear from each group. So you're not going to want to miss that part either. Before we send you into random rooms where you don't know what you're going to be talking about or who's going to be there, we're actually going to ask each of our team leaders to speak briefly about what it is that we are going to be working on in their room. So we have a playbook and resource guide team. Dr. Grady, are you there?
I am. Thank you.
Wonderful. Can you give us a quick little synopsis of what you guys are going to be working on?
Sure. The state level work group is developing a playbook and resource guide to support state work groups that are working to support primary care for all. Our vision is that the playbook will provide a menu of options so that anyone, no matter their experience, can find a way to help PC4AA achieve our goal. The only requirement to become a member of the work group is that you are interested. So please join us during the breakout and share what you know and learn about our plans. Thanks.
Wonderful. So let's hear from those state work groups. First, we have Rhode Island State Work Group. It's co-led by Dr. Blanchette and Dr. Fox. Dr. Fox, can you just give us a little bit about what the Rhode Island State Work Group is going to be talking about tonight?
Yeah, so tonight we're going to be talking about two pieces of exciting legislation that are before the Rhode Island legislature to boost up primary care. One is to support practices to train primary care physicians, nurse practitioners, and PAs, and the other is a tuition program to entice young physicians, nurse practitioners, and PAs to go out, get their training, and then for every year that Rhode Island pays, spend 2 years providing primary care in Rhode Island. So we're looking to address the workforce shortage in Rhode Island, and we're looking to get to know you guys and get some leadership on our team.
And
awesome. Thank you so much. Yeah,
can I just mention we're very lucky to have Senator Pam Lauria joining that work group. She's on with us, and the Rhode Island State Work Group will be able to hear from her in just a minute.
Excellent.
Wonderful. Very exciting. We also will have a Mass State Work Group led by the one and only Dr. Altman, who was a previous speaker of ours. Dr. Altman, can you give us a little synopsis about what the Mass State Work Group is going to discuss tonight?
Good evening, everyone. We have been working for 5 years now on some very bold legislation in Massachusetts that doubles primary care investment and shifts the predominant payment model for primary care from fee-for-service to a prospective monthly payment. This legislation was filed about 15 months ago, and last Wednesday, was the deadline at midnight for it to come out of committee. I was notified at 7 p.m. that evening that it came out of committee and is going to go to the Senate Ways and Means Committee and skip over one committee where it often gets stuck. So double good news there. And so we right now, fresh off the presses, need to discuss next steps and would love to hear folks' feedback and ideas.
Wonderful. That is great news to hear. Just a little plug right here. If you are from a state that has over 10 PC4AA participants and are willing to chair a state work group from your state, please email PC4AA, add your information into the chat, get in touch with us in some way. We'd love to launch some more work groups. The states with more than 10 participants so far are California, Connecticut, DC, Massachusetts, New Hampshire, New York, Ohio, Pennsylvania, Texas, and Virginia. So if that tickled your ear, please jump into either Rhode Island and Mass to hear how they are doing what they are doing. But let us know that you'd be willing to launch your work group as well. We also have a great engagement work group led by Dr. Bauer, who is, right there. Can you give us a quick little synopsis of what your group is all about?
Sure. The engagement committee was responsible for designing the process of training facilitators so that each of those chapters, be they a state chapter or a local chapter, can get about its business. So we've mapped out a process, and we'll be talking about that process in our breakout session and beginning to brainstorm some specific activities that people can get involved in to move things forward at either the state or at the local level.
Wonderful. It is very important to be engaging more people as we work to build a movement through this community. And one of the ways that we do that is through our social media team led by Dr. Khan and Dr. Gantz. Can I have one of you please describe what you guys will be working on in your work group tonight?
Sure. So I'm Fatima Khan. I am part of the Family Medicine Physicians at JHMC. Visibility is viability. In the age of fast-moving trends and short attention spans, the key to outreach is the multiple social media platforms. And they can help us connect with like-minded medical collaborators and audience who have unmet healthcare needs. So join the work group to amplify the PC4AA message.
Wonderful. So hopefully one of these groups really stood out to you, but maybe this is your first time or you are early in joining our teams. So you might want to hear a little bit more about what is PC4AA all about. And we have a group just for you. Our newcomers group or new recruits group is hosted by the one and only Dr. Alan Roth. Dr. Roth, could you describe what that group is all about?
Thank you, Patty. Yes, so I'm one of the board members for Primary Care for All Americans. And if any of the previous things didn't strike you, or if you're new to our group and want to find out more, what we are about, what we're doing, and how you could join and help us, I'd love to talk to you in one of those breakout sessions soon.
Wonderful. So some great groups to join. Hopefully one of them caught your attention, but we are going to be moving into the toughest part of this evening, making a decision.
In addition to money to help coordinate the curriculum, it is going to have the Department of Health help run that and identify the 30 sites. And then it will provide money for those sites that can either be used for decreasing the clinician's schedule so that it's easier for them to have a student and then it compensates the site for that. Or if they don't think that they can lose that productivity, they can give the stipend to the clinician as a compensation for having the work above and beyond what they normally would do. So that's the one bill. The second bill is direct tuition scholarship bill that would provide in 4 years. It would do 5 medical students full tuition with the promise for 4 years, full tuition, with the promise that they would come back and work in Rhode Island for 8 years. And in the same 4 years, there would be 2 full cohorts of nurse practitioners and physician assistants. So at the end of the 4 years, there would be 10 NPs and 10 PAs with the same promise of 8 years. There's 2 full cohorts because their program would be for 2 years. So that is, looking at a way to, in the medium range, try to put an influx of primary care providers into Rhode Island. The scholarships would be prioritized for Rhode Islanders, and particularly with an eye towards equity and inclusion. So that's kind of the snapshot of those 2 bills.
Yeah, no, that's fantastic because we are, I'm in pediatrics, and I can tell you pediatrics we're hurting. But honestly, we keep our really, really high patient panels to make sure that, kids in Rhode Island have somebody to go to. But once they graduate from us, it's almost impossible to find them a home with adult providers. And I can tell you, talking with parents in my office every single day, most of the parents I talk to are really struggling to find doctors for themselves. And so, when I'm sending kids out, it's on a wing and a prayer, unfortunately. And, the parents, really are really struggling to find that primary care. So the more the merrier in primary care in Rhode Island. We really appreciate you introducing these bills and supporting them. And, we're also, grateful for Representative Fogarty, who has introduced them on the House side as well. So we'll be supporting those all the way. We can't lobby as part of this group, but we can certainly educate and chat up all of our friends.
Yeah, so the good news is that this is, coming into the session, this was a priority of the Senate President to work on this issue. The CTC has statistics that we could be down as much as 100 primary care providers.
And so this will give us some focus, shared focus. And then this is the question-based plan is what are we assuming, what's unclear. We're going to translate those into questions and then talk about how we could answer those questions. The small experiments are really going to be the things that move us forward. And that's designing experiments and then doing them and then learning from them and then scaling them and spreading them for the ones that work. And then next steps is just how we keep the whole thing going, how we keep the momentum. So the idea is to keep growing the group, growing the experiments, growing our vision of what success is. You'll notice this is my last point, Larry, with this whole thing, is that the way we work is we work from the perspective that communities move in the direction of their conversations at the speed of trust. Communities move in the direction of their conversations at the speed of trust. And stuck communities talk about what's wrong, who's to blame, and why it sucks to be us. Stuck communities. And if you want to grow change, you have to change the conversation to what would we love to see possible, what do we have available, and what could we try to make progress toward what we want to see possible. So that's really the architecture of the process.
Thank you, Jack.
In a nutshell.
So one of the questions that I have, or one thought that I have, is let's just imagine over the next 6 months, hypothetically, we have 10 or 15 state groups, state level groups, and we have another 10 or 15 local groups, each doing small experiments like Jack is talking about. From my point of view, there's a hell of a lot of learning that can happen very quickly about what is possible, what kind of impact can be made. The assumption, I believe, is that primary care is stuck and it's going down the tubes, and that things are just getting worse. But I truly believe that there's a lot of very good things going on and a lot of very good things possible when people are organized like this and all these experiments are happening. And as the news about those is shared, both within our group, the Primary Care for All Americans, as well as within the larger public through the social media committee that's also starting up. As the news of that goes out, I think the belief and the hope grows that change is really possible, which I truly believe it is. So this process can go from 0 to 60, I think, quite quickly if we have those groups organized, following this process. So I'm going to stop right here and ask if folks have questions or comments, reactions.
I want you to think about, I want to invite all of you to think about when it comes to engaging people on the ground, right, to move this forward. What should we keep in mind? What should be on the top of mind when we think about how we engage people to grow primary care in these small locations? What's important? What should we think about? What should we include?
I'm a little concerned how we're going to do all this with the number of people we have at the moment. I think the first step might be to engage more people, certainly for the zip code groups. I don't know if there's anyone else from Pawtucket or 02906, which I also know. And the one basic thing I would say is that your description sounded in many ways like a tenant union I belonged to in the 70s. And we were extremely successful because we didn't sit around and complain. We got out there and we got 20-something landlords, lawyers, and inspectors convicted of arson. And we then bought property and rebuilt some of the housing. But one of the things that I remember from that and that I'm seeing here is it's tricky inviting people to get into a group and to join, especially if, everybody's busy, and the people who are going to be the most affected and need the help the most, either the practitioners or the people who can't find a doctor, are going to have the least time and energy to be in this. So we need to put it out in a way that's inviting and that really shows these positive things. And one thing I've been a little frustrated with, sort of a semi-side thing, is that I really would like there to be something that's the size of a business card, or maybe twice the size of a business card, a quarter of 8.5 by 11, that has a summary of our group, the website, a physical thing that I can give to my doctors when I go to appointments, because unfortunately I have a merry collection of things, so I go to a lot of doctors, and they're that kind of thing. But it needs to say more about what we're about.
Right.
But where do I even get those? Because it also gives legitimacy to what I'm saying. And a few doctors know me well enough, they gave me their email and I sent them the link. But that kind of thing I think would be better. Anyway, that's enough out of me for the moment.
That's a great idea.
Well, Larry, the card you showed had a QR code in the corner. What does it connect to? Just the website?
Yes, takes you right to the website.
On which we have what Eliana is asking for, right? The website has what we are about and what's going on and so forth.
I will say I checked the website before there was a special meeting, emergency meeting, and I had just sent the link to 3 of my doctors, and the special emergency meeting was not what was featured on the website. The meeting that had happened the week before was what was up there. So I'm not trying to complain, but just it's if we're going to use that to promote stuff, we have to stay really on top of the website. And I tried emailing people to say that and nothing happened. So I know we're all volunteers and that's how it goes sometimes, but I just wanted to mention that part. Also, some of us don't have any ability to make anything out of a QR code. You have to have the phone that does that. And
that's true.
So putting out actually, I meant to do it, making a tiny URL for the website so that somebody could type it in without getting bothered.
Right.
A good idea.
Another great idea. So one of the things I'd like to challenge the group to think about is what kinds of activities, whether it's the state level or the local level, what kinds of activities might people do that would allow them to get engaged with the process and to move forward the issue of primary care in their respective catchment area. So, for example, one of the things that came to my mind was people could volunteer to either contribute to or start a blog that talked about their experience in the area. And over time, that blog would attract attention and help grow a community of people of interest. Other thoughts that people have about activities?
Does the blog attach to the website, or is that, I'm not so up on all the social media.
Well, there's a place for blogs on the website, but it also could be, there's a number of platforms now that are available that actually don't cost anything. Jack, you have a blog and you blog regularly. Do you want to comment on that?
Yeah, I mean, blogs are good for this. Well, blogs are good for a couple of things in this kind of process. One is educating people on what we're doing in the movement. The other is telling stories, success stories, which hopefully eventually and not in the long-term future, but near-term future, we end up having success stories. So people could see, like, in Cleveland, I would love to see what's happening in Rhode Island, right? And be inspired by that, or what's happening in Oregon, or what's happening in Denver, or wherever. So I think that's another, and yeah, all these things can be linked to and from the website for sure. Yeah.
Jack, you just reminded me of something as you were presenting the framework that Larry had done a screen share on. Is there a structure yet to share the outcome of these little experiments? So how do we get the word out in some kind of formal, structured way so that you can see what's going on in Denver and hear about it and think about it?
I don't know. We've got a lot of so Len, I was on early, and we have all these social media people, and so what I don't know if they have a plan, but that's a social media plan, or I'm sorry, a communications plan, right? So the key with communications in this kind of movement is you want your tentacles to go out as far as you can. So you want things on the website, you want the blogs that Larry's talking about, you want Facebook, all the social media stuff, you want handouts, right? Physical, right? Like you're talking about. You want as many different ways to communicate success stories as possible. So I don't know. That's a good question. I don't know who's doing that, but Larry.
I think that group is actually, they're meeting right now, trying to figure out the answer to that.
Oh, okay.
Yeah, that group is just starting also.
Excellent.
Can I ask you all a question about what kind of stakeholders are you ideally trying to target as you're discussing all these different messaging platforms?
That's a great question. So initially, the stakeholders that are going to be really meaningful to us are primary care docs or primary care teams, not just physicians. People who are like the hyper referrers to primary care people. Okay, so those could be schools or clinics or God only knows who, we don't care, but the referrers are really, because we want to grow the network, right? So residents, right? Anybody in a primary care residency program, we want residents, and also what Larry calls patient advocates. right? Patients who really want to be a part of growing primary, so they're, their whole attitude is primary care is just the best thing. How can I help this thing grow? And they become some of the volunteers, right? Possibly in some of these experiments. There's one other group that's interesting from some of the success stories around the country previous to the movement here, are employers. Because these are people who can underwrite primary care for their employees on a totally different financial level. It's like ridiculous, the difference between making the poor insurance companies richer because they're in such bad shape. You're right. So it's doing that, or it's doing the whole primary care model, and their employers who are really excited about that. It's like, yeah, I'm all for getting away from the poor insurance companies.
Yeah. So I think something that's not been mentioned, I think if you're, I'll give you some context. Is I work at a urgent care and large primary care practice in Texas. I'm family medicine. And employers are just motivated by finances. And I found that people that are prolific on the internet that talk about how primary care impacts employer health, that is probably a really interesting way to get into that fold. So there are folks like Eric Bricker. He's a doctor of finance healthcare expert. He does a lot of whiteboard sessions. And so I think if this group started putting out some sort of content that actually educates about, it doesn't need to be lectures, but I think it's just something that is shareable. This is how to get on the radar of those decision makers.
Nice. Yeah, it's great.
So Scott, you're muted. Thought you were about to say something there about employers.
I was just asking Paulus, is it Police? How do I say your name?
It's Paulius, like Julius.
Paulius, okay. What city in Texas are you in?
I'm in Houston.
Okay, very good. I'm in Dallas, so there we go. So, the thing that's coming up for me is, A, obviously I'm very supportive of this idea, but B is, it feels like, and I don't have the answer to this, so I apologize for putting out a problem without an answer. It feels like, as Eliana was saying, we need somebody that's a spark plug that would take this and kind of have the organizational energy to get it put together. Because there's a lot of people who want to contribute to it and support it, but don't have the bandwidth to be the organizer who actually drives everything. So I'm wondering, like in Dallas and Houston and San Antonio, we have 3 large cities. We should have groups going in all of them. But I don't know how we find that energetic person in each community to organize it and put it together. And, again, Jack, using multiple different modes of asking for people who are interested and hoping that we get the whatever generation they happen to be in, whether they're a retiree or a person who's really young and energetic, that's seems to me to be something we've got to try to figure that out. Because there's a lot of us who would be fast followers and very supportive, but we aren't at a place we don't have the bandwidth to lead.
Yeah. Well,
Yes.
to your point, Scott, very good point. But to your point, the ideal scenario, because of people who have time, meaning not babies and children or whatever, the best scenario in leadership is really co-leading when it comes to social change. And what that would mean is somebody like you or me, I don't know, you're probably younger than me, but you have people my age in their 70s and somebody in their 30s paired together. Okay, that's the ideal leadership model. Is you have those.
Hey, I'm 36. Let's do it.
There we go.
I'm almost 70, so we're
Paulius and any of the old people here. Okay, good.
Yeah.
So, but that's what we're talking about. Is you have to have the energy and the wisdom, both. And I'm not saying the energy doesn't have wisdom doesn't have energy, but you get what I'm saying.
I do. I understand. And it definitely is a team initiative. It's got to be, And, so Paulius, what do you do during the day? What's you're a primary care clinician, you said?
I'm happy to catch up offline. I don't want to take up the group setting. I kind of do a little bit of everything. Yeah. I see patients. I do technology.
Okay.
Yeah.
Yeah. Okay. So yeah, maybe we need to figure out this for Texas, because I think it's going to come down to regions and getting a critical mass in each region, and we just have to figure out how to do that.
Yeah.
So
Well,
I think Scott's making a great point. Jack makes a great point. I want to throw out there real quick. I know we're down on time, but the COPD Foundation, I'm on the board, and same issue. How do we do engagement? And what we ended up with for grassroots engagement was an electronic town square kind of place where we call it 360 Social. And it's got this neat technology structure where people can say, hey, I want to co-lead with somebody. Let's break off and make a little section over here, and we'll figure out how to do that, and we'll share it with people. We have moderators who kind of don't let people go off to the wrong direction, keep them on track. We've got captains, people designated as captains. Usually they're patients who have COPD, but not always. They could be a pulmonologist who wants to be a captain, but it's somebody who kind of wants to organize the thing and make it productive and structured. So just throwing that out there as one idea of how to get engagement.
What are they breaking off from? You have
well,
like
somebody might.
meeting? You have a monthly meeting or something when you say they're like breaking off from-
Sometimes they decide that the best way to do it, that little group, that discussion group might break off and say, we're all about how do we get the attention of Congress and get the funding we're supposed to get. And they work on that. So another group might say, nobody's doing research on a cure. Everybody's talking about just managing symptoms. How do we generate interest in engaging people who want to research a cure for the disease? Another
Right, but I'm
group
saying,
might.
what are they breaking off from?
The general 360 Social electronic town hall platform.
Okay, so it's a platform that's always up, or you meet once a week, or?
No, it's always up. It's a web space kind of carved out on general web space. You can go to 360 Social. It's just the name we gave it.
Like you.
They can talk. They can set up visual forums. They can do asynchronous typed in communication and wait for somebody to return a message. It's very flexible.
Okay.
Intimately flexible, but the goal is engagement and then move forward, keeping forward movement happening.
I wanted to say something. Slightly separate, but I'm in a Sjogren's support group, Sjogren's arthritis, on Facebook, and it's not visual at all. We just type things in and people comment like a Facebook page.
Okay, great. That's great. So, so
do we have to like swear in for the official record?
So, so the one thing I asked everybody is why were you interested in becoming part of this work group? So I'd really like to hear from you as well. What interests you about this?
Very much a systems person. I've been operating under some premises I've been trying to prove in healthcare, one of which is I think you can operate high quality primary care under the margins of state insurance. And this is a premise I've been trying to prove on a very micro level in the region I'm in, in this idea of hyper local focused primary care. So I've been working with a couple other providers on that, and I was hoping to come in and steal your playbook. And I found out a few moments ago I'm coming in to help you make a playbook, and so here we are.
You can put your imprimatur on it. So when you say that you cannot, I think I heard you say you cannot provide high quality primary care within the margins of state insurance.
No, you can. I'm saying my premise is that you can.
You can. So the thing I hear from physicians all the time is that Medicaid does not pay enough. So is that really what you're saying, is that yes, you are being paid enough? Or if you are paid in a different way, perhaps you could use the money the same.
I'm arguing that I think very local, low overhead primary care can be delivered in a high quality manner
under the margins of Medicare or Medicaid. That is the premise I'm trying to prove. I do not have that in working order to come back and prove that premise.
Okay.
But that's my interest in this, in some of the interest in the space. And then I was, like I said, I was coming to steal your playbook, and now I'm interested to know what we're building and how I can help.
Yeah. So, I think that's really helpful. So, if you were looking for a playbook, what are you looking for in a playbook? What do you want to know? I mean, I have some ideas. I think one of the things that we learned the other day in this session that we had with John Riccuti was that you really need to get the worst mistake you can make is to not reveal your assumptions, and that this kind of approach of questioning helps outline, expose those assumptions. And so I really would like to ask people, what do you think this is going to look like? What do you want to have out of the playbook? I have some ideas, but I'd like to hear from other people.
I have some ideas.
Go ahead, Brian.
So I became really excited about what Primary Care for All Americans was doing when I first heard about the idea, but it was just a big idea. It was very, very broad. And very quickly I got to asking regularly, but like, what's the concrete thing we're going to do?
Yeah.
Where's the action? What are you asking us to do? And I think that the founders of the organization have some good ideas about that, but they're not written down and they're not in any detail anyway. And so I'm excited about this group because I believe it's going to actually manifest the thing that I've been wanting to see since the very beginning. And again, I don't know exactly what that is either, but I know that like the idea, one of the big ideas is that every community is different. Every state is different. There's not one answer to how to pay for primary care for everyone in each community. There are dozens or hundreds, let's hope it's dozens of different ways to accomplish this. And it's going to be different in red states and in blue states and in wealthy communities and in low-income communities and all of that. And so I think one of the challenges that this group faces is that it's not one playbook, or it's one playbook with a lot of chapters. But I do think it can be, I mean, maybe there's a way to start with the idea of it's going to be different in different places, and here are different ways we can go about it.
Right.
And
so the playbook is supposed to be for the state work groups.
Yeah.
And that has caused me a puzzle because our state work group's starting, but I don't really know what they are doing. And so I'm concerned about how those, I think there needs to be a little bit more communication about that. And I actually have some ideas about, how to do that. But it seems to me that one of the things that the state playbook can do is sort of set the standard, that there should be a work group that sort of defines the problem for the state, especially in terms of workforce and Medicaid policy. And so, yeah, every state is going to look different. If you go to, Vermont, they've been working on this for a long time. They have, statewide plans, and Rhode Island has sort of set the standard in terms of primary care spend. And so it seems to me that there are certain things that the state work group should say, they should be looking around and saying, looking at the distribution of the primary care workforce, and then saying, for our state, it should look like this. But they need the data in order to do that, and they need some information to go about, what is reasonable, because basically what we're trying to do is to start restart what was abandoned in the 80s, and that is healthcare planning. We have not done any planning for healthcare in decades, you know, and so now we need to set the standard, and it's going to have to happen, you know, at the state level, because the federal government is frozen. So I think that so to me, that's what the state playbooks sort of should look like, is what's the standard for our state in terms of what we should be seeing in terms of primary care workforce, what are the kinds of models of primary care that will work in our state. You know, we've been and how does it get paid for, you know, especially by, you know, what is Medicaid doing in our state to innovate, and if we provide people with, you know, resources where they can look at various case studies, they might say, we want our state to adopt this, or, you know, this model with revisions or something like that. Does that make sense? Does that resonate with anybody?
Mm-hmm.
Okay. Yeah. So I'm on the right track. Okay, so Brian, you raised this issue, you know, of there's a lot of big ideas, but bringing it down to the ground is really, really challenging. And you know, one of the questions that I asked was in the first meeting is, what action do we want people to take once they've accessed the playbook? You know, how is it going to be set up to drive them to action? Did not get good answers to that question. I don't know, Jim, you were at the meeting. I don't know how much you remember, but you know, when you think about action, when I asked that question in this group, what's the answer? Because Brian and David, you're both, you weren't in the other meeting. So what do you want people to do once they have access to the playbook, or be able to do?
Sorry, were you asking?
Anybody.
Okay. I mean, I think, oh, go ahead, sorry. Go ahead. I was gonna say, I think like my understanding, and I'm brand new to this meeting in this space, but would be that it's an understanding for the state work groups to know how to organize effectively, to understand how to identify problems and barriers to implementation of community-based care for all, to identify resources or have a strategy for resource identification at the state and local level. And then potentially, based on what I was hearing about what the other groups are working on, they're working on legislative activation, or right. And so like I know people are doing that in different states. That's a very different, it's similar, but different state to state. And so I'm thinking of imagining kind of that framework of the recipe that the state level organizations could pull from some of those frameworks, but they're still going to have to apply them. Because coming into these group, my question is like, great, what can I do to help? And I don't have a target. I think that framework might help create some of that target. That's my general thoughts, but it's not fully grounded yet.
So I think that those reflect things that I have thought, except the first one, which is how to organize effectively. So I'm not sure that I think it's an important topic, but I don't have any insight into how the state work groups are being formed presently. It's more like you want to, and are they getting support? Brian, do you know if they're getting support from any other part of PC4AA?
As we are having this meeting, the first state work group is having their meeting, their first meeting also. So I would imagine they are saying a lot of the same things that you're saying, which is we don't know yet what we're going to do.
Okay.
So there's not an answer to that question.
No, but there is, in the sense that Dr. Fine has, introduced this concept of cardinal roles. He's been working with this group Momentum, which is a sort of a social movement incubator. And I gather that they have a model of organizations. So I will make a note of that. And because, you know, we might not want, that might not be in our playbook, but we might say, you need to go here to get that resource.
I mean, they give you an example of some stuff we did in Suffolk County. We had what's called a Long Island Health Collaborative, it was working with the state. And we did surveys of the population. What were the important issues to them? What healthcare needs did they identify in their communities? And then we brought together large groups of community organizations to meet and try to coordinate their services together. And so I think what we'll be seeing is that every community, and whether it be a county or just a town or whatever, will have different needs and have to modify or use different parts of the playbook for their particular community. Because some communities are very sophisticated, they know what they want. Others have not been included. They don't know what they need. They don't know what they want. And you also have to collect data. So we would collect surveys, use the state's data to help educate the local communities. And we adopted specific goals, obesity, vaccinations, whatever, such things such as that, to engage the community and to measure our effectiveness.
So, but you know, building collaboration, it's great when you have the right mix of people and it looks right, but finding the right people and then educating people about what collaboration needs. So you're putting even more in the chat.
That's just the same things. That's just what I said before, but in written form.
And I did. That's great. But you know, so that organizing effectively, building collaboration, you know, that I'm not sure whether, you know, that's something to think about. I think we need to sort of put it in the parking lot and figure out where the resources are within PC4AA in order to do that, because I think we're basically going to have to take what we can get in terms of people who are willing to do the work. And, you know, I mean, having worked in rural areas a lot, you know, if you just don't have the right person, sometimes it's a single person, you know, to move something forward, it can be really very difficult.
Is this work group considered, do you think it's going to be prescriptive or descriptive, in the sense that there are state working groups that are working on something? And is the goal to describe what they're doing to replicate, or is the goal to prescribe what they should be doing?
I think, you know, I think it's almost a little step back for that, to give them a set of resources where they can figure out what it is that they're supposed to be doing. I wanted to touch on the issue of advocacy as well. You mentioned legislative, then you said advocacy on the state and local level. That is where my mind, you know, almost automatically goes to legislative policy and whatever. PC4AA is a educational 401c3, and I think Dr. Fine wanted to sort of step back from the legislative policy part of it. But personally, I think that one of the things that could be included in the playbook would be model legislation. So Dr. Altman has this bill, what is it?
PC4U.
PC4U. You know, I haven't seen the legislation, but it seems to me that there's issues like that. And then around data, you know, we really can't do anything. We have such poor data on the workforce, and that was big part of my job, and people don't seem to sort of recognize that you can't just say, oh, we just don't seem to have enough primary care physicians. Everybody's got a long wait time. And having the actual numbers, how many they are, where they are, what the wait time is for an appointment, how much care, some way of estimating the delay in care because of lack of workforce is really important. So, and that's one thing that could be the subject of legislative policy that isn't quite as much as in your face as PC4U. There's various levels of legislation. So, I mean, even giving people access to, go here, if you want to figure out how to know what's going on in your General Assembly or your legislature, whatever you have, you need to go here. This is where you can usually find that information. So I think a lot of it is going to be like that sort of more general. You should know about these things. You're going to have to figure out how to do it in your state. So in that sense, it's
the legislative.
Yeah, go ahead, Brian.
The legislative is a piece of what the state work groups are going to have in their toolkit. Tonight, it just happens to be that Rhode Island just passed this piece of legislation and they got the state senator to come to the meeting. And so that's what they're talking about. But I don't think we should be distracted by that into thinking that, oh, this is about state legislation. It's not.
Right. I just, just sort of sharing my weakness, which is to think about state legislative policy. So
it seems to me, and James got into this a little bit, that I think there's two needs. One is the needs assessment, that if we find the right person or people in an area to spearhead this and actually get stuff done, they're going to have to do a needs assessment, and they probably won't know what that means, or certainly won't know how to do it. And so if we can help them with a document that tells them, like guides them through what that means, that would be great. And then another thing that you were in the meeting with Jack last week, weren't you, Margaret?
Yes, I was.
Yeah, so he was talking about resource assessments.
Yes, asset
assessments.
Yeah.
Which is a different way of, it's like looking at the solutions first rather than the needs, the problems first.
Right.
I think they go hand in hand. But
we have 21 seconds left.
Getting something that's very specific to people.
I made a note. Think about asset mapping for the playbook. And it's broader than just how many medical schools you have. It's what kind of talents.
How many churches do you have?
Yeah, exactly. So program services, there's a lot of things that he included. And I also want to, we're not getting bumped out. Usually it'll automatically send you back. But I do want to talk more about what he talked about, that question-based planning and how to ask those questions. So, okay, we're supposed to be leaving the break room. They're all going to close in 23 seconds or 21. So why don't we just all go back and make life easier for the folks on the other side.
Groups, whether you wanted to or not, you're being forced back into meeting with the rest of us, and we are looking forward to hearing just a little snippet from everyone. Looking for, Dr. Fine, there you are, the man of the hour. Did you have a good, what group did you pop into?
Into playbooks first, and then into the Massachusetts breakout state work group.
A man on the move. Well, we want to hear from all these different groups. So actually, you know what? Let's get started with that playbook and resource guide team group. What did you guys talk about?
Well, we talked a lot of things. For one thing, we got a new recruit, we got a new member, David Nichols from XPC outside of Philadelphia, came looking to take advantage of our play group and found out that he was actually going to help us build it. So we talked about two major questions, and that is, what do you want to see in a playbook? You know, David was somebody who was looking for something. So what was he looking for when he came to the playbook? And you know, the answers were pretty much what we talked about in our first meeting, which was, you know, what are the barriers and challenges? How do you find resources? What do you do about legislation? And the other thing was, the question that we asked was, you know, what is the action that you want people to take? We didn't completely answer that question, but we did come up with the idea that what we want the state work groups to be able to do is to have the resources so they can set the standard for their state of what primary care for all should look like in their state, because we know it's going to look different in every state. So I think that over the next couple of months, as we put this together, we'll be trying to put together all of those resources that will allow the state work groups to have the resources that they need to do that.
That's great. We love having good platforms to jump off from. And so thank you to that group, and excited to hear more in the coming weeks and months. So let's jump over to those state work groups and hear a little bit about their discussion. Rhode Island, can you give us just a quick little snippet of what you guys talked about?
Yeah, so we spent about half our time talking with Senator Loria about some bills, not only the two bills that she introduced for workforce, but also, you know, kind of the big picture in, you know, getting better payment for Rhode Island primary care docs to recruit and retain physicians in Rhode Island. And then we did a roundabout of the group to see all the amazing experience that we have in Rhode Island. You know, physicians, coordinators, community health workers, musicians. What am I missing here? Primary care militant. We have one of those.
And a couple of nurses.
What was that?
And a couple of nurses.
And a couple of nurses. Yes, excellent. I seem to keep leaving the nurses out, and I apologize for that, Len. All right, so it was a great discussion. We ran out of time, and we're cut down to the last second.
I love that. You know, it's a good discussion when you get to the last moments and you just want a little bit more. You always want them leaving wanting more. All right, so for the Mass State Work Group, Dr. Altman, did you figure it all out?
Yes, we have it all figured out. In fact, in the time since we left you, the legislation has passed.
That was yesterday, April.
Congratulations.
I've extended April Fools for the whole month, I've decided. Yeah, we had a very good conversation in terms of how to engage specialists, how to engage Medicaid in Massachusetts, and collaborate with them. And how to strategize how to pay for investing in this in primary care investment. So we brainstormed all of those issues.
Perfect. It sounds like you did part of the work of our next group, which is our engagement group that's coming up here. Dr. Bauer, are you there?
Yep, I'm sorry, I didn't realize I was muted.
Oh,
so,
as long as you didn't run out on us, you're good.
No, I'm here. So we had a nice conversation. We reviewed the process that the engagement committee has created that's been approved by the steering committee. So the process that we will use at the local level and the process that we will use at the state level, we talked through that. And then we talked a bit about what methods might we use to engage people in activity at those two levels. And there were a number of ideas that were suggested. One of them that I thought was So we have business cards now, at least some of us have these. And the suggestion was that we have key information put on the business card, because there are people who are not into technology, and they'd like to be able to hand a piece of paper that does more than takes them to the website, but has some basic information on it. So I thought that was actually a very helpful idea. We talked about the need to figure out, and I think the social media committee is probably doing this. How are we going to share success stories from the experiments that will go on at the state level and at local levels? And a question was raised about which stakeholders are we targeting. And Len Fromer mentioned something called an electronic town square. He's on a board for COPD organization, and they use this. I've never heard of this before. So it's something that we might want to look into, but it sounds like a wonderful process for engaging people at all levels. So that's what we were talking about.
Sounds like you guys got a lot of discussion, and very exciting to see what comes out of all of that as well. You mentioned social media. That was the team that I got to come hang out with for a little while. Can we have you guys share what we talked about?
Sure. Thank you so much for joining us and for facilitating a robust discussion. So thanks a lot for that. So here are a few things that we've come up with. Thanks to your help. Being clear about what the voice of PC4AA is, then the cadence of posts, so how frequently we'll be posting across the different platforms, and some action items and a timeline, a realistic, practical timeline that A is achievable and B is helps us get to it quicker. Like we should have started yesterday. So that is the timeline we are going for. And we now have a clear idea of what are the priority items going ahead. And it has been great that things are clearer now. The ideas are now converted to action items, which makes things easier.
Sounds great. You guys are fabulous as a team, and it was a pleasure talking with all of you. Social media is something that all of us can participate in very easily, so we look forward to engaging many of you in that process. Speaking of engaging people and new people in particular, Dr. Roth, how was your discussion with our newcomers?
I think we had a great discussion. I think people were open with questions. We talked about what primary care for all Americans is and what it's not, and trying to keep a little less political and inclusive to everyone, that everyone we want to join our organization and be a part of it. The entire team has my email, so I think I'm going to hear from everyone on that call. There were 7 newcomers, and all had great ideas about next steps for the organization. So I think we have great new members who I think want to help us and are aligned with us and helping us align with other organizations. And I think the one thing was, how do we connect us all together? Was a good suggestion, that those that are willing to post either their initials or emails on the websites, that we could start communicating and reaching out to local people. So I gave everyone my email, aroth@jhmc.org. So I'm happy to anyone to email me, but especially the newcomers, to see how they could participate in our organization. And they all had great things to say and great ideas.
Wonderful. We love to hear that. Building the movement. I'm getting excited. Dr. Shafi, you getting excited?
So excited. I think the breakout sessions were a huge success tonight. We encourage everyone to bring someone new to our next Zoom meeting. It'll be on April 16th. We'll hear from Dr. Wayne Jonas. He'll be talking about healing works, advanced primary care for all Americans. You can register on our website, www.primarycareforallamericans.org. And while you're there, click volunteer. Let us know how you'd like to be an active member. And also click donate to support our work together with a contribution. Every little bit helps. Once again, we need and really appreciate every single one of you for joining us tonight and helping to spread our movement across the nation in order to get the change we need and you deserve. Join us again in 2 weeks. Bring as many people as you can. Healthcare for people, not for profit, primary care for all Americans.
We have a great opportunity for everyone to complete a survey. We are building something big and we need to hear from you. We need your participation. So we have this Google form that I've dropped into the chat box here. We do go through those every week and look at your feedback. We want to hear from you.
Sorry. I believe we have a few moments at the end. Some of our board members will be sticking around at the end of the Zoom call to answer any questions you guys might have. Other than that, thank you again so much, everybody. See you on April 16th.
I was wondering, are we going to meet again as little groups?
We will be, these groups, what we're going to do is we'll do this once a month, and once a month we'll have a talk. So the next meeting I think is April 16th when we'll have a talk, but the following one, which is probably April 30th, we'll do exactly what we did tonight.
That's Passover. I'm out of it. Sorry.
But there may be some well,
Other
we may
people, right. Yeah.
we may have to program that in and figure out a different approach to that based on that date. But we can improvise a little bit. And I'm hoping that each of the groups will meet between these Zoom meetings to continue the work that got started tonight. Other questions? Anybody? Hearing none, why don't I say thank you to everybody?
Good
Thank you
night,
to everybody
everybody.
for participating, for everybody who worked on putting this together. I mean, think of what an amazing thing. We now have 5 work groups working on, you know, not just learning, but working on doing, changing the reality on the ground. How fantastic is that? It's the way you build a movement. See you all in 2 weeks.